Good evening and welcome to our ongoing series of webinars from the New York-Presbyterian Morgan Stanley Children's Hospital. This evening we'll be discussing insulin and innovation, an update on type 1 diabetes treatments and research. And we have a very distinguished panel who will be with us this evening. And to introduce them, we have Dr. Robin Goland. And Robin, if you will begin by introducing our panel, and then I'll take it from there.
Thank you. It's a pleasure to be here. I'm Dr. Robin Goland. I'm the J. Merrill Eastman Professor of Clinical Diabetes in Medicine and Pediatrics at Columbia University and NewYork-Presbyterian Hospital, and the co-director of the Naomi Berrie Diabetes Center. It's a great pleasure to introduce the speakers tonight. We have Dr. Rudy Leibel, the other co-director of the Naomi Berrie Diabetes Center. He's the Murphy Professor of Diabetes Research and the chief of the Molecular Genetics Division in the Pediatrics Department, and a basic scientist who will tell you about his research in diabetes and obesity. We have Dr. Barney Softness, an associate professor of pediatrics and a wonderful clinical pediatrician, both a general pediatrician and a specialist in pediatric diabetes and endocrinologist. And Dr. Natasha Leibel, who is an assistant professor of pediatrics in the Division of Pediatric Endocrinology. She's the head of the Pediatric Diabetes Program and the head of the team at the Naomi Berrie Diabetes Center, both a clinician and a clinical investigator and educator at Columbia and the Diabetes Center.
Very good. Thank you, Robin. And just a couple of housekeeping notes here. If you have any questions, we'll try to get to them as we go along here. There is a Q&A box at the bottom of your screen there on Zoom. Also, the entire webinar is being recorded and then will be posted on our YouTube channel probably by tomorrow, I believe. And then, so you'll have a chance to refer back to that as well. And I have asked our panelists if it is all right with them to be a little less formal, and I will address them by their first names so that we don't sound too stiff and too boring up here. We hope to give you some really interesting and very important information here. So let's begin with Barney. Why don't we start with you for a second here, just to make sure that we're all on the same page and everybody understands, because I know we have some parents of diabetics out there who are also viewing tonight. Define type 1 diabetes for me. Tell me exactly what that is, please.
Sure, Max. Thank you. And thank you for having me here, and it's a great pleasure. So diabetes basically very simply means high blood sugar. And there are several types. Most of you might have heard of them. Type 1 diabetes is an autoimmune process where, the body makes an immune process that actually destroys the insulin-producing cells. And essentially, people are deficient in insulin so that they have high blood sugars much of the time. That's as distinct from type 2 diabetes, which may or may not actually be insulin deficient, but it's not what we're talking about here tonight or today. And diabetes, or at least type 1 diabetes, was formerly known as childhood diabetes or juvenile diabetes. And some might still use that phrase, but we really don't like that or encourage that anymore, because whereas it is true that perhaps 50% of kids diagnosed with type 1 diabetes are between the ages of 9 and 14. That's really a common ages for it. But we are seeing it in much younger children, even as young as 1 and 2-year-olds with increasing frequency. And it's being diagnosed by our adult endocrinologists at all ages. So in the 20s, 30s, 40s, and up. So it's really not just a childhood disease anymore. And in fact, people are at risk of missing that diagnosis if they assume that an older person can't have type 1 diabetes.
Got it. Good. Thank you. Now, Rudy, let's talk for a second here, because type 2 diabetes is also high blood sugar, but it's really a very different disease. Tell me a little bit about that and how they're different.
So if you take most populations in the world, about 90% of individuals with diabetes will be diagnosed with type 2 diabetes, and 10% or so type 1. And the distinction between these, Barney alluded to, is that in type 1 diabetes, there is an immune assault against the beta cells of the islets of Langerhans in the pancreas. And in type 2 diabetes, the insulin deficiency is not absolute in the way it is in type 1, but is relative to the body size and body metabolic requirements of the individual. So type 2 diabetes is insufficiency of insulin for the metabolic demands of the body. And most type 2 diabetics continue to make insulin. They just don't make enough to meet the needs of their bodies. And this is the reason why obesity is so frequently associated with type 2 diabetes, because it is the stressor that ultimately causes that insufficiency of those beta cells to become clinically apparent.
And the beta cells, just to be clear again, those are the insulin producing cells in the islets in the pancreas, right?
Correct. Correct. The islets of the pancreas actually have many different cell types in them, at least 6 probably, but the major one that concerns us with regard to most instances of diabetes is those insulin producing cells.
But Rudy, I've also heard type 2 diabetes, and I don't want to get too far afield away from type 1 here, described as insulin resistance or insensitivity.
Correct. And that's what I was alluding to. That is, it's not that the pancreas can't make insulin, it can't make enough to meet the peripheral needs of the body. And this is often referred to as insulin resistance, because the increased body weight, body fat of many individuals with type 2 diabetes causes them to respond to the insulin they make less efficiently than they would if they were not obese. And that's the basis for the term insulin resistance, which in turn stresses those beta cells so that they can't meet the needs of the body.
Got it. Got it. Natasha, just to sort of finish off our type 1 diabetes 101, tell me these beta cells that Rudy was just describing are in the pancreas, and they are what? They're sensing blood sugar and then responding up and down with insulin, secreting insulin into the blood? Is that how that works?
That's exactly right. So the way I like to describe it to families who, for example, are just diagnosed with diabetes is when we eat food, the food is digested and from there absorbed into our bloodstream. Insulin is the beta cell will sense the amount of sugar in the body, release insulin in an appropriate amount to help move the sugar that we've consumed into our into our cells of our body from the blood where it's used for energy. So consider insulin as like a key that unlocks the door to our cells to allow glucose or sugar to move in where it's converted to energy. So that is really the role of insulin. And the beta cell can really sense the amount of glucose in the body and therefore respond appropriately with the amount of insulin to be released.
And in the process of allowing blood sugar to move into the cells, that's what lowers then your blood sugar so that it doesn't get too high, and that's what we call diabetes.
Exactly. And the body will maintain that sugar in a very tight range. Generally, blood sugar should be between 70 to 140 milligrams per deciliter. And people with diabetes, their sugar can go upwards of 1,000. So, that's what can happen.
So, Robin, what happens? Why do we worry about such high blood sugar? Why is that a problem? And how does that affect type 1 diabetics then over time?
Well, so as Natasha said, the body generally tries to keep the blood sugar in a pretty tight range. And the good news here is the care has gotten better and better to help us help the patient keep the blood sugar in that range. There are some short-term consequences when it doesn't stay in that range. If it gets too low, that could cause, that's called low blood sugar hypoglycemia. That's not good for you. That could cause you to be shaky and sweaty and have a seizure and become unconscious. Very scary. We like to try to prevent that. And if it gets too high, you feel pretty sick also. And you feel tired and you urinate all the time and you can be quite sick. Over years, the high blood sugars can damage the body and cause pretty significant complications. So the people on this panel that devote a lot of time to taking care of patients work really hard with the families and the patients to try to help them keep the blood sugar in that range. It's a huge amount of work, which is why Rudy and colleagues are trying to help them not have to live their lives like that, because it's tiring, it's debilitating, and it's hard, and it's a little scary, but we've gotten a lot better at it.
And is it fair to say that hypoglycemia, too low blood sugar, is sort of a short-term, immediate, acute crisis, whereas the high blood sugar in general is something that happens that is detrimental over a longer period of time. And that's why we worry about how long a person is a diabetic or not a well-controlled diabetic.
So that's mainly right. So there are short-term problems with both low blood sugar and high blood sugar. And there are definitely many long-term problems of sustained high blood sugar. The technology, which I'm sure we'll get to, has helped us and helped the patients both predict and prevent the scary low blood sugars. And that, in the course of my career, has been a huge advance.
So, Barney, as a sort of a practicing pediatrician out there, what do you see? Why are we seeing more children get type 1 diabetes? And is it just in children, or we're seeing it, as you said, as you alluded to earlier, we're seeing it really across a number of all age groups, really?
Well, that's a hard question, Max. We are definitely seeing more diabetes, more type 1 diabetes every year. You know, estimates range from about 3 to 5% more cases every single year. And the big question is why, which we don't quite have an answer to. You know, the original concept of type 1 diabetes is what's popularly known as sort of a two-bullet hypothesis, and that is to say you need two hits. One is perhaps a predisposition to have an autoimmune disease of some sort or an autoimmune event. And then the second has been, you know, what is the second bullet, the second precipitating factor that sort of makes your immune system start to attack your own personal islet cells. And not only have we at Columbia been involved in sort of large multinational research sort of endeavors to try and figure out what that is, but it's been happening worldwide for a long time. And the answer is not satisfying in that no one has found one single thing that sort of brings on type 1 diabetes, or that second bullet. You know, it's been speculated to be certain viruses, speculated to be even certain vaccines, which seems to be ruled out, all kinds of, you know, various insults that might be it. And it turns out that all those things do it in different people. So, you know, we can't sit here and say, oh, this is what causes type 1 diabetes. But we do know that it's increasing to the same extent, you know, that we get concerned that asthma is increasing and food allergies are increasing, and people sort of discuss and debate what this might all be about, but we don't really have that answer yet.
And that first bullet, so to speak, is thought to be generally genetic, a predisposition?
Yes. you can actually do genetic testing. You can look at what's called the HLA complex of genes, and they can there are different genes that we can identify that say or predict that someone's going to be higher risk for type 1 diabetes, and actually in some people that they're quite resistant to type 1 diabetes, and that can be identified. It gives you a number, but it doesn't actually, tell you anything. But when we do some of these studies that look for determinants of diabetes, we can often do them only in high-risk individuals that increase their chances, or that have increased chance of getting it, and therefore we have a higher chance of sort of seeing an effect, even if we haven't yet.
Natasha, what are some misconceptions about diabetes? I hear this all the time, that I ate a lot of sweets, or my kids eat a lot of sweets, and that puts them at risk, and so forth. What are some misconceptions, and can you straighten us out on that?
So that, I think, as you said, Max, that might be the number one misconception. Type 1 diabetes does not come from eating sugar, nor can it be prevented by eating no sugar. So it simply is, as Barney said, it's the interplay of genetics and our environmental, a trigger that we don't yet know what that is. And it is not related to amount of sugar from diet choices. It is not a lifestyle condition that can be treated by simply removing sugar from the diet. And it's also really important to know, if you are a child with type 1 and you're still growing, you still need to eat sugar and you need carbohydrates. And in fact, if you restrict this, you will have a very negative impact on a child's development and growth. So we really encourage children with type 1 to eat very normal diets, and that includes treats and so forth. I think another misconception that I think is important to point out, especially now in light of COVID, is that there's confusion between having an autoimmune condition and being immunocompromised. So a lot of times people with type 1 will confuse that they're immunocompromised, meaning their immune system will not respond to an infection properly. And that's not true. So a healthy, an otherwise healthy child with type 1 is not at a higher risk of infection compared to any other child. And I think that's really important to point out.
But as Barney also alluded to, if there is a child in the family that has type 1 diabetes, the other kids or other siblings or other relatives may be also, or are also, at risk?
That is true. That is true. So your risk in the population is about 1 in 300, risk of getting type 1 over your lifetime. That risk will go up substantially if you have a first-degree relative who has type 1. And Robin and Barney have both been very involved in trials where we study to look for that level of risk in first-degree relatives of people with type 1.
But looked at another way, your risk of getting type 1 diabetes is still greatest if you have no relatives.
Yes.
So, I reassure people that just because you have a relative with diabetes, yes, your other relatives have an increased risk, but it's, still not certain that they will get type 1 diabetes, because, you want to make sure that people aren't unduly frightened.
Right. This increased risk is maybe goes up to 5 in 100. So 95% chance of not having diabetes.
Right.
And the flip side is that if you don't have a relative with type 1 diabetes, does not mean that you're immune or out of the woods, right?
Right. Most people with type 1 diabetes will have no one else in their family who has it.
Correct.
Rudy, we talked a little bit about genetics and predictive values, and I've followed some of this with acquaintances and people I've known professionally about antibodies. We were talking about, I know one family who has a teenage daughter, type 1 diabetic, and they've been following the other daughter, their antibodies, and they say they can tell from their antibodies that it's only a matter of time before she also becomes a type 1 diabetic? Can you explain that to me? How does that work?
Once the immune assault gets going, whatever it is, as Barney said, we don't exactly understand the trigger, but we understand some of the genetic sort of predicates for that. Once that starts, the body begins to generate antibodies, not so much to cause the type 1 diabetes, but as a response in many ways to the attack, so that you can tell that there's an attack underway by detecting the antibodies. Now, they're not perfect. Well, the clinicians should say more about this than I do, but you can have antibodies and not go on to develop full-blown type 1 diabetes, and you can develop type 1 diabetes at least early without having a great deal of antibody response. So the clinicians use the antibodies to track other members of the family and individuals who look like they may be developing type 1 diabetes as a way of tracking the intensity of the assault on the beta cells in the islets. And it's a way of monitoring the activity of the disease. And again, as Barney alluded to, it's one of the screening processes that are used in some of the studies that are done at the Diabetes Center for trying to pick out individuals who may be at higher risk of ultimately developing full-blown type 1 diabetes.
But they're not perfectly predictive.
Well, we can measure 5 antibodies, and now the assays have gotten much better over the decades. And so if an individual with a first-degree relative has more than 2 antibodies and they're persistent over years, then we can assign a risk of that person going on to get type 1 diabetes. And if you look at their metabolic status and there's any evidence that the glucose is at all a little abnormal, those people have about an 80% chance of getting type 1 diabetes in the next 5 years. So they can be helpful because then there are studies people could sign up for. And also we could prevent people from ever being sick. You know, often these are families that know what it looks like so they could catch it early anyway.
And Robin, speaking of studies, can you prevent type 1 diabetes, whether if you have these autoantibodies or you have a sibling? What can you do about it?
Well, there are a lot of groups, many at the NIH that are certainly working on this. We should have this panel every couple of years because I would like the answer to be yes. There was a big study of a drug called teplizumab that looked like it could certainly delay type 1 diabetes in antibody positive people with abnormal blood sugars. So that was a good signal, not a home run, but interesting. So the answer to your question is, can we prevent it? Not yet, but boy, is it a good goal to work toward.
So in a way that kind of, and let me throw this out to any of our panelists really, plays into a question that we got in here. Interestingly, this person says both their father and brother presented in their 70s with type 1 diabetes. Should this individual then be tested, or siblings, if it happens to be a child, be tested for these autoantibodies, and then what?
So they can be. Right now the screening, I believe, is family members who are up to age 45 in this study that is being done actually around the world. That's correct, Robin? So I think 45. So that is unusual to present that late, but we have absolutely seen cases where a child will have type 1 and then the parent gets it. So it definitely can happen, and you certainly can screen. And I think, you know, if you want to know the answer to it, then by all means, I think go ahead and screen yourself for the antibodies. I think it's a really reasonable thing to do.
I diagnosed type 1 last week in an 80-year-old woman. She's doing great.
So speaking of screening, Barney, what are some of the symptoms then that usually parents would be looking for? We hear a lot about some of these things, but describe some of the symptoms for me, please.
Well, the usual symptoms that are often popularly recognized are as your blood sugar starts to rise, and you know, you've been undiagnosed, so you don't realize that, it does make you sort of, you're going to urinate more, and because you're losing the sugar, the extra sugar is being sort of filtered out by the kidneys, and it brings more water out. Mm-hmm. So you urinate more, because you don't have insulin and that sugar is not going to the cells, you're not getting really proper nutrition, so you're losing weight. And so the very common ones are, you know, going to the bathroom a lot, and therefore drinking a lot, and also you're eating a lot. It's not really going to good use without insulin in your body, but you're sort of eating and drinking and then losing weight. So sometimes we've had people diagnosed, especially if they are very familiar with diabetes, when someone they wake up in the night once when they never usually do, or they wake up in the night twice and they never usually do, and they get diagnosed relatively early. But if it's not recognized then, as blood sugars go even higher, people lose more weight, they get more dehydrated, they get quite sick, and they can actually, the pH balance in the body gets all upset, they get acidotic, and then really what happens later on is usually vomiting, stomach upset, and ultimately, you know, altered mental status, and certainly in the hospital by then. So, you know, keeping an idea out for these signs as early as possible. We love for people to get diagnosed as early as possible so they don't get super sick like that. Mm-hmm. And the other thing I would say is that all is very reasonable, everything I just said, in your standard child and teenager and adult, but we are seeing diabetes more and more in the younger set. And so you're not going to be able to tell a lot of that in a 2-year-old and a 1-year-old. Yes, some mothers had said the diapers are just sort of completely filled way more than they used to be. But, you know, unfortunately, a lot of toddlers, they get diagnosed maybe after their 3rd trip to the pediatrician because they were sick, they weren't looking well. And it's not something that, you know, primary care doctors or maybe anybody's going to think about with a baby throwing up, but it sort of should be in the back of everyone's mind just a little bit. Little kids might not present with these classic signs.
They might have this sort of failure to thrive. They're not gaining weight the way they should.
Well, yes, that's possible, but it would be more of an acute weight loss. You know, I don't usually, and it's true that some people can present with type 1 in a rather simmering way, but many times, once they've gone over the edge, they present in a rather acute way. So someone who's obviously not gaining weight appropriately, they're going to check a bunch of different things and end up checking a blood sugar as well. But usually it's more of an acute event and acute weight loss.
And just one more thing about symptoms there, because I've heard from parents who have children who are doing sports, and of course they get very thirsty and they start worrying about it. Excessive thirst by itself is not necessarily the issue. It's this constellation of symptoms.
Yeah, I would say yes. I mean, obviously excessive thirst and excessive drinking can lead to excessive urination. So it does get pretty complicated. But, you know, if someone has it for 1 day or 2 days and then it goes away, that's not diabetes. It's sort of going on and on, relentlessly.
Got it. Rudy, let's talk a little bit about the future and research here, because there is so much research that I'm aware of going on in this field. What do you find sort of the most intriguing or promising now? And then we'll delve into that a little bit more.
To me, and Robin alluded to this early on, our goal is to make this disease go away. That is, to have a patient who has the disease be cured so that they do not any longer have to attend to the kind of incessant clinical attention to this, insulin administration, glucose testing, and so forth. So to me, one of the most fascinating possibilities, and this is work actually going on in the Naomi Berrie Diabetes Center is the ability to cause cells in the intestine, which are related closely to cells that are in the islets for embryologic reasons, to trigger the gut cells to make insulin. And we've actually done this. Dr. Mimo Achille in the Berrie Center has done this in a way that involves manipulating certain genes in the gut cells, and it can cause these cells to make insulin, to become like little beta cells so that they sense glucose, respond to it appropriately, and can actually prevent and then reverse diabetes in a mouse, quite successfully actually, so that we can take a mouse, administer this kind of medication to it, even though we have knocked out all of its own beta cells, and the gut alone will support this. And there's currently effort underway screening a whole variety of small molecules, as we call them, that would permit an individual to take a drug like this by mouth that would instruct the intestinal cells to make insulin, and that insulin would replace the missing beta cells that have been destroyed by the immune attack on the islets, so that the individual would become what we would refer to as insulin sufficient. That is, they could control their blood glucose by having their gut cells make the insulin that their islet cells can no longer produce. And to me, this is an extraordinary promise for pretty obvious reasons. I mean, if it works or could be made to work, this would be an enormous advance, obviously.
And kind of a variation on that, I'm aware of also using some different drugs or small molecules to goose the regenerative capacity left in the beta cells in the islets, even in type 1 diabetics that have gone pretty far down the road, to get them to regenerate themselves?
Yeah, Max, this is a very interesting point. It hasn't come up yet, but it's been implied, I think, by some of the things that have been said. Individuals who have type 1 diabetes generally don't present clinically until they've lost about 80 or 85% of those insulin-producing cells in the pancreas. So it's a very silent disease. And this is one of the reasons for the interest in the antibodies, because they will tell us, at least in appropriate clinical circumstances, that an individual is under attack, so to speak. And those are individuals in whom, by appropriate use of the kind of agents or approaches that you mentioned, it might be possible to goose, as you said, the beta cell in the islets. And there are a number of ways to do this. And again, without getting too much into the weeds here, it looks like partly what goes on in these islets is that the beta cells are not necessarily lost. They change their cell type. Again, this is a complicated issue, but one of the things, again, that we've been investigating is how to make them revert back to beta cell status. The other things that have been talked about or tested, as you alluded to, is to make other cell types in the islet, try to differentiate them towards being beta cells. So you're absolutely right. There are many different approaches to this, but in two major classes. One is to try to make the islet make more beta cells, or at least revert other cells towards insulin production. And the other is to make the gut, which is, again, as I mentioned, in terms of its embryology, closely related to the islets, make insulin de novo in a way that they never did. And it may be a combination of these that will, in some instances, be appropriate for one type of patient and the other for the other. We just not far enough along to know the answer to that.
But wouldn't the gut beta cells also be susceptible to attack by the autoantibodies?
Yeah, this is a very interesting point. It looks like the gastrointestinal tract, or at least to the extent that there's been studied to date, may be more immune privileged, as we say. In other words, the insulin producing cells there won't be seen by the immune system in the same way that those in the islet are. But it's a very, very important question, and it's still early days in terms of determining whether or not that would be the case.
Interesting.
In the animals, that doesn't look like it happens. But again, need to study this in humans.
Interesting. So Robin, let's talk about another approach to a cure. And it's an area that I've been interested in, but that we hear a lot about, and we've heard a lot about over the years, but it seems that they're not quite ready for prime time, and that's some version of cell therapy, stem cells, or some way of replacing these insulin-producing beta cells. Where are we with that end of that approach to treating or curing diabetes, type 1 diabetes?
So this is another exciting area that is under study at Columbia and all over the world. So the concept here is if we take a skin biopsy, for example, from a patient, now our colleagues are able to take those skin cells and turn them into cells that can make any cell in the body. And from there, make them into beta cells. And we're doing it. And so similar to the concept with the gut cells, the idea is, could we then make enough of them to be able to put them back into somebody with type 1 diabetes? And to preempt your next question, didn't that person already reject those beta cells the first time? I'm going to give you the same answer that Rudy gave. Yes, but maybe they'll be enough different that the immune system won't kill them, or else they won't, and we'll have to do something to make them so-called stealth beta cells. Or the patient will have to take immune suppressing drugs, which seems like not the greatest option. As the care for type 1 diabetes gets better and better, the bar for the research to cure it also goes way, way up.
And one other approach that I'm aware of is taking these new beta cells, exogenous from somewhere else that we've now differentiated into beta cells, and putting them in some sort of protective environment so that they aren't going to be attacked, and they can continue to sense glucose and secrete insulin. Whereas, has that gotten very far? I know of a couple of approaches that, or companies that are trying that.
Well, so the approach you're describing is called encapsulation. Mm-hmm. And I've been hearing about this for 30 years. I so far haven't seen it work. I don't know, Rudy, are you aware of successes here yet?
There is a clinical trial now underway using encapsulated human beta cells derived from stem cells. So we will know the answer to this. And it may be that, you know, the first couple of tries at this won't be as effective, obviously, as later or subsequent approaches. One of the problems with the encapsulated beta cells, at least so far, is they have to be transplanted to parts of the body, for example, under the skin, that's not exactly where you have a normal functioning beta cell in the pancreas. So their efficacy may be more limited than if they could be placed into the liver, for example, which is where we do islet transplants, which is a much older, but again, in some instances, very effective treatment. It's just that the number of islets that are available from humans, for pretty obvious reasons, is limited. So there have been other efforts to make beta cells, of which Robin just alluded to one, which is to make them from stem cells. There have been also thoughts about having them generated in other animals, such as the pig, and again, moderate or modulated in terms of their immune structure so that they wouldn't be seen by the body, a human, as foreign. So there's a lot of effort underway to make beta cells. And the reason I particularly like the gut story is that's just converting cells you already have into insulin-producing cells. And should mention your question, Max, about the immune attack on those is a very appropriate and excellent one. And not to sort of set that aside, but let me make the following point. There are instances of diabetes in humans, type 2 diabetes as an example, but there are also single gene mutations that produce diabetes in humans that do not involve immune assault on those beta cells, those individuals presumably could be given their own beta cells back, meaning by stem cell transplant, without having any immune assault on it, because it's them. You know, they'd be getting themselves back. So
you have to fix them first, is what you're saying.
Yes, but in other words, I'm saying that those cells would not be necessarily susceptible to immune assault as they might be in a person with type 1 diabetes. So there are other uses for these cells other than just in type 1 diabetes.
Interesting. So Natasha, we've been talking about the future here, but meanwhile, we have many type 1 diabetics that we have to take care of now while we wait for stem cells, small molecules, whatever. Tell me about, and again, Robin alluded to, we've gotten so much better at controlling blood sugar here, or managing it and trying to keep it in that physiologic or normal range. Tell me about where we are. What's the state of the art there?
Right. So I've been taking care of children with type 1 for almost 15 years. And the change in the way we manage it now is really, it's exponential in how different it is than when I started. And if maybe there's some pediatricians who are on this that remember giving 2 injections a day and making sure that the child ate at certain times so their blood sugar didn't go low, or, I mean, that is like the Stone Ages now of diabetes treatment. So it's really tailored to the individual, and we can individualize their management and their doses so much better with the kinds of insulins we have and the technology, which I'm actually going to show you. So many of I'd say most of the pediatric patients go on what we call an insulin pump. So I'm showing you an example here. It's like a beeper. You wear it on your, attach it to your pants, let's say, and then there's a very small needle that goes right under the skin, and this tubing the insulin goes through the tubing, and this will deliver insulin every hour in a fixed amount so that you're always getting some insulin. And then every time the wearer is going to eat, they enter how many carbohydrates they're going to eat, press some buttons, and it delivers a bolus of insulin in relation to their blood sugar and what they're going to eat. Another kind of pump, actually, this is the whole thing. And so it just attaches right onto your skin, and you control it by using something that's almost like another phone. We also now have, and I think this has really revolutionized lives for so many patients and their parents, who now actually can sleep, because this, I hope everyone can see it, is what we call a continuous glucose monitor. So you can see it's really thin, and again, you wear it on your body, and what it's reading is the glucose that's in our interstitial fluid. And in fact, this has a very tiny sensor that inserts right under the skin that will read your blood sugar every 5 minutes to up to 5 smartphones. So it could go to the mom's phone, the dad's phone, the babysitter's phone. Everyone can be watching the child's blood sugar. And not only does it tell you what the blood sugar is, but it tells you if the sugar is going up or down, or if it's steady, and then it will alarm if it goes too high or too low, so that you can actually, in the middle of the night, for example, if you're sleeping and the blood sugar drops too low, it will alarm and you can get up and attend to the blood sugar. So I'd say the most advanced pumps that we have right now are what we call the artificial pancreas. And the idea behind that is that you take the sensor, you wear the sensor, and you wear the pump, and the sensor reads the blood sugar right to the pump. And then the pump can make decisions on its own about increasing your insulin dose or lowering it, depending on whether your blood sugar is going up or down. And those pumps work really, really pretty well, and they get the blood sugar into the target range way more than sort of traditional management can, and can really help improve the A1C. So the technology has come very, very far.
So that CGM, the continuous glucose monitor, which I'm sure a number of us have seen the commercials on television these days, but I've heard from a number of endocrinologists that really has been a game changer. That's really that. And then of course the ability to talk to the pump has really changed our ability to manage blood glucose.
I think it is, I would say it has really revolutionized the game, because I think in terms of feeling comfortable as a parent that you know where your child's blood sugar is, or for yourself, if you're the wearer, to not have to constantly prick your finger. And we would have patients who, just the other day, we put a pump on a 23-month-old, right? So that you want to know what that child's blood sugar is doing all the time. And 10 years ago, you might be checking the blood sugar 15, 20 times a day. And that's very painful and very burdensome. And now this really takes that away. And I think it's really just a lot better.
That's terrific. That's terrific. Barney, one of the questions some of the questions that we're getting here have to do with autoimmune disease. If type 1 diabetes is an autoimmune disease, are then the children who develop it or the adults at risk for other autoimmune diseases? They seem to come in pairs or threes sometimes. What is that true, and why is that?
Well, the why is going to be a little bit harder, but you're exactly right, Max. So if someone has a tendency toward autoimmunity, there is a possibility, and they are at higher risk for other autoimmune diseases as well. And what's interesting, that diabetes does run, the tendency to get diabetes runs in a bit of a cluster with two other autoimmune diseases. Autoimmune hypothyroidism, which is sometimes known as Hashimoto's disease, and celiac disease, which is, as you might know, a gluten sensitivity, also an autoimmune disease. And so patients with diabetes are a little bit higher risk in the general population of getting those other diseases, and we screen for them. So in a general pediatric population, you wouldn't screen for these things, I don't think, ever. But our patients, we screen not exactly once a year, but close to once a year with these, and it's completely independent of their blood sugar control. It does not, whether you are taking good care or bad care of yourself, but they are at higher risk, and we often pick them up, sometimes symptomatically, but most of the time we pick them up sort of pre-symptomatically or asymptomatically.
Got it.
So, yeah.
Robin, we mentioned, we've talked here about, and Natasha mentioned the advances there in delivering insulin, but I've also keep hearing about sort of, obviously, insulin itself has changed in a sense. Human insulin that was genetically engineered now some time ago made a big difference, but we still have to sort of inject or have a pump that puts the insulin in. We hear about other ways of delivering insulin, like inhaled insulin. Is that a viable alternative for some people?
Well, right now, probably the best way to take it is through injection. And we're all hoping that the time course will get shorter and shorter, so the onset will be quicker. Many of the inhaled insulin products have had a lot of side effects. And so I am not using it very much in my practice, not at all, actually. I don't know about my colleagues. Are you using it?
No, the dosing is not appropriate for pediatric patients. And as Robin said, there's been problems in the past. So we are not using it now.
Got it. Rudy, I've heard the eventual cure for diabetes described as a, is it a two-legged or three? But it better be a three-legged stool, where we have to control the autoimmune disease, and then we have to either replace or repair the damaged beta cells or the missing beta cells. So those are kind of two separate research paths then towards a cure? You're on mute.
Myself. I like to often make the sort of analogy about the two men running away from a bear, and one of them turns to the other and says, "How are we going to beat the bear?" And he says, "I only have to outrun you."
Right.
So in terms of the ultimate management of diabetes, you know, or its cure, what we need to do is both ideally suppress, as you said, the amount of assault on the beta cells and do something to increase their mass or number or efficiency. And basically, we've been talking about those two limbs throughout this interview, so to speak, the immune attack and the various things we can do to the beta cells. Ultimately, my fantasy, if you want to call it that, is that what we will develop is a vaccine, basically, that will prevent the assault in the first place, so that we'll shut off those cells that are looking for the insulin-producing cells in the pancreas, and that will be an immunization that's given to children in exactly the same way we do for measles or hopefully at some point COVID-19 and other infections. I think it's it's a possibility. And I think a recent history with the COVID has shown what science can do in terms of developing vaccines against very, very specific types of assaults, meaning in this case, a virus, in the case of the beta cells, to shut down that T cell, which is the primary immune cell that assaults them before it ever happens. And I think ultimately that's that's maybe the goal several decades away. And some of the other things we've been talking about are sort of interim fixes. It's trying to suppress the immune system, which Robin alluded to, and some of the things to do to replace the beta cells that I talked about. But ultimately, we want to prevent the disease. And I think it's doable.
That would be the home run.
That's right. That's
Sure would. One of the big issues that we alluded to again earlier, Barney, with type 1 diabetes are all the long-term complications, the eye damage, kidney damage, heart disease, and so forth. Can we prevent that in any way other than by strictly controlling the blood sugar? Is there anything else that can be done to keep some of that collateral damage, as it were, from happening?
Well, this would be a question more for my adult colleagues, because the good news is that we, in pediatrics, as kids are being diagnosed younger and younger, we have the potential to be seeing some long-term complications while they're still in childhood, but that's with better control that we're seeing these days, it's very, very rare for us. So we hopefully don't see it very much at all. There are, other techniques to help with diabetes complications. There are medicines for kidney damage. It doesn't really fix it. It sort of helps it a little bit. And there's ways to treat eye issues, by ophthalmologists. But obviously the key is to keep the blood sugars as good as we possibly can. And obviously it's a very difficult and long-term challenge. And so the goal is to sort of make it as easy as possible for people to do it. And Natasha even alluded to stuff that starts doing it a little bit more automatically. And so making it sort of easier for people to do it for a much longer term, get much better sleep is the bigger, much more important way to do it. But, I would say, as Rudy implied as well, let's prevent those complications instead of fixing them after they happen.
Right.
And as the adult colleague, the good news is that in order to prevent the complications, most of them, the microvascular, the small blood vessel ones, are very tightly linked to the blood sugar. Nobody should smoke, but I'm growing old with my type 1s. And we are creating a whole cohort of people that didn't used to exist, the elderly type 1s, a more stubborn group you never met in your entire life, because they've outlived every prediction. And we and every other diabetes center, people with type 1 that got it as children who are 50, 60, 70, 80 years old. It's remarkable. And I think now with the advent of the pumps and the algorithms and the sensors, people are going to live a very long time and be healthy. But we do have to pay attention then to preventing heart disease and stroke and watch their blood pressure and lipids and all the standard things the rest of us need to pay attention to. But it's very glucose centric to begin with.
Got it. So before we wrap up here, I hate to, I can't avoid or ignore the elephant in the room. And that question then goes to you, Natasha. Are people, particularly children with type 1 diabetes, any more or less at risk for COVID-19?
So the good answer is no. Children with type 1, as far as we can tell now from all the studies that have been done and been looked at in populations around the world, children with type 1 do not appear to be at high risk for contracting COVID or for having any complications if they do have COVID. And we certainly have seen some of our patients at our center who have had COVID and have done just fine. There's also been, a lot of things in the news about diabetes and COVID, and that diabetes is a very high risk factor for having morbidity and mortality from COVID. And that certainly appears to be true in patients with type 2 diabetes, especially older patients with type 2 and patients who are obese. So there is a very smaller subset of much older patients with type 1 who appear to have been sort of poorly controlled over decades, who appear more vulnerable to COVID. But this does not appear at all to be the case in children with type 1 diabetes. And I will defer as well to my other colleagues to see if they want to add anything to that.
Well, we're actually almost out of time. So let me wrap up here. And I always like to ask our panelists for a pearl of wisdom, a take-home message that you want our viewers and listeners to take home. And Barney, you get to go first.
Well, I think the important thing, and I do tell this to a lot of my families, is to have a plan in place. The world, not surprisingly now, is things are always unexpected. Things are always happening. And so people should have a plan. And so someone with diabetes, even more importantly, whether it's obviously travel, you have to have a backup plan in case your pump breaks, you have to have a backup plan in case you lose your bag of insulin, but even going to school, or even staying home, I think families should always sort of have a plan for the unexpected, for emergencies. We do get a lot of calls after hours. The one insulin bottle they had broke, they don't have any more insulin. Kids with type 1, that means going to the emergency room if you don't have insulin for even half a day. So I'm a big proponent of having an emergency plan.
Yes, it is a lot of work to manage it. Rudy, help us out here. What do you want us to remember about type 1 diabetes?
What I want you to remember is that the ability to manage this disease now by clinicians such as those who are on this Zoom is so extraordinarily good and getting better that the threshold for our intervening in some of the experimental ways that we talked about is getting higher and higher. So I think a point to remember is using current clinical management in the hands of very expert clinicians can basically normalize the longevity and the general health of an individual with this disease, which could not have been said a decade ago. So the advances just in the clinical management have been extraordinary. And I think the science at this point is extremely promising that ultimately this disease can be taken out of the hands of physicians. And as we often say, our diabetes center will become a bowling alley so that people won't even remember this disease at some, number of decades from now. That's my hope anyway.
Good deal. Natasha, tell us what you would like us to remember from tonight.
So I think for, every child I have met who has type 1, their diabetes is different and their experience is different. And I think to really respect that as a clinician, that, you know, everyone is carrying this differently and their body responds to it differently, and they live with it differently. And to always remember that it is never something that someone did that caused them to get type 1 diabetes. And I really do hope one day we can prevent it.
Great. And Robin, the good news is you've had a chance to think about your pearl of wisdom. The bad news is they've probably already
said it.
But as the co-director, we'll let you wrap up here.
Okay, well, I agree with everything my friends and colleagues said. I recall Sam sitting in the waiting room as part of a clinical trial with a little IV. He was a little tiny kid, and another little tiny kid asked him what he was doing. He said he was in a diabetes study, and this kid said, Sam, someday we're going to say, remember Sam? He used to have diabetes. And I think about that, and that is the goal here, and that's where we're headed. On behalf of everybody who's watching this, that's what we're trying to do here for you.
And I couldn't agree more, actually. My take-home message here, because I have been a medical journalist for, I almost choke on saying this, for 40 years, and have watched the evolution of this field, and it is absolutely breathtaking. Where we are. I have friends and colleagues with children with type 1 diabetes. And the message that I give them, and that I think I want to wrap up with here, is hang on, the cavalry is coming.
Yeah.
We're going to get there, and I do believe we're going to get there very soon. It really is true. So thank you all. Thank you to all our panelists. This was an amazing, informative evening, and thank you all for listening. This again will be available on our YouTube channel by sometime tomorrow, so you can go back and refer to it, but hang in there. There's help on the way. Have a great night, guys. Stay safe and wear a mask, please.
Thank you.
Thank you.